None of the producers have any financial interest in the products or procedures shown.
T-minus 90 seconds and counting. Off its 3 onboard fuel cells. Booster ignition and liftoff of the Space Shuttle Discovery, returning to the space station, paving the way for future missions beyond.
Pressure works in various ways. It helped us launch rockets, cook our food, even build our great Earth. Pushing through many layers of the Earth's crust, the volcanic magma found its way onto the outer surface to form the very Earth we stand on. In this video, we describe the effect of pressure on a coloboma cataract. We also explain a new and novel technique of solving this pressure effect via the vitrectomy-assisted phacoemulsification for lenticular coloboma. A lenticular coloboma case in a textbook or a slit lamp is a wonderful diagnosis and looks quiet, but on an operating table it can be a cataract surgeon's nightmare. The problems encountered intraoperatively are often unknown to the naked eye, pre or post-operatively. Hence, diagnosing these issues intraoperatively is of utmost importance. Some facts about lenticular coloboma. Lenticular coloboma develops due to defective development of zonules that cause flattening of the lens equator, resulting in notching in that region owing to the lack of zonular pull. This is hence a misnomer, since there is no loss of lens tissue. These patients develop nuclear sclerosis cataracts much earlier in life. They could almost be called coloboma cataracts. Other associated findings in the eye could be coloboma of uveal tissue, heterochronia, microphthalmos, retinal dysplasia, posterior staphyloma, subluxation of lens, and many conditions. Coloboma lens can be associated with these many systemic conditions. The problem: in coloboma cataracts there exists an anterior-posterior communication through the area of the coloboma. This area is devoid of zonules or consists of defective zonules. Now let's understand what occurs during a cataract surgery intraoperatively. The typical surgery begins keeping low infusion settings and profusely injecting viscoelastic material at the site of the coloboma to prevent any vitreous prolapse into the anterior chamber. The rhexis and hydrodissection is usually uneventful. Now, in a coloboma case, during nucleus removal, the phaco probe adds an excess amount of saline, which, via the anterior-posterior communication, enters the posterior segment and swells the vitreous body. This vitreous swelling, in turn, can create two changes. 1. When the coloboma size is 0 to 3 clock hours, the swollen vitreous pushes the iris bag diaphragm up towards the cornea, causing shallowing of the anterior chamber, thus preventing the free movement of the phaco probe and risking both endothelial damage and posterior capsular rupture. 2. When the coloboma size is more than 3 clock hours, swollen vitreous herniates through the coloboma gate, which in turn rips the remaining zonules, leading to instability of the bag. The proposal: for these cases of coloboma cataracts, we describe a new and novel technique of vitrectomy-assisted phacoemulsification. Step 1. The surgeon pre-places a trocar 4 mm away from the limbus and away from the site of the coloboma. Step 2. Follows the steps of cataract surgery, from making the incisions to placing pupil expanders to rhexis to hydrodissection, taking care of the rhexis margin at the coloboma site. Step 3. The surgeon then starts the phacoemulsification and during the procedure slowly starts experiencing a positive pressure where his or her phaco probe faces restriction in movement. We denote the elevated intravitreal pressure by pushing in some viscoelastic into the eye. Watch carefully here. The blob of viscoelastic just comes gushing out when being injected. Step 4. It is at this point that instead of using pupil expanders and capsule tension ring, we recommend removing the phaco probe and inserting a vitrectomy cutter through the trocar and cut anterior vitreous behind the lens, taking care not to touch the bag while cutting. Then continue phacoemulsification. Use capsular hooks when the coloboma size is larger than 4 clock hours. This prevents the nuclear fragments from falling into the retina. Step 5. Now intermittently use the cutter to remove the hydrated vitreous whenever facing a shallowing of the anterior chamber. Step 6. When approaching the irrigation part of the coloboma cataract, we must all understand the nucleus was distending the bag, and now that the nucleus is absent, the bag curls up on itself and does not allow a proper cortical matter removal, as the zonular countertraction that is needed for the cortex removal is absent. Hence, we recommend a capsule tension ring implantation to distend the bag and also cover the gap of the colobomatous area. Step 7. Inject viscoelastic and place an IOL in the bag, usually along the axis of maximum zonular instability, thereby preventing an IOL tilt. Step 8. A pupilloplasty is done wherever needed and the case is closed. Measuring the coloboma. From the coloboma seen at the pupillary edge, an imaginary line is drawn over the iris towards the limbus till they meet. Now, the measurement taken at the limbus in the form of clock hours denotes the size of the lenticular coloboma. If 0 to 3 clock hours, vitrectomy-assisted phacoemulsification is an ideal technique. If 3 to 5 clock hours, vitrectomy-assisted phacoemulsification with capsule tension ring and iris hooks will be ideal. If above 5 clock hours, due to the bag IOL size mismatch, we recommend to do a secondary IOL implantation of your choice. Advantages of this procedure: retains capsular bag integrity, keeps the content of posterior compartment from prolapsing into the anterior, prevents corneal endothelium from damage, improves anterior chamber depth intraoperatively, avoids risk of posterior capsular rupture via phaco probe, avoids need for mannitol and other adjuvants to reduce IOP. A peer-reviewed article in JCRS February 2017 edition has been published. All in all, vitrectomy-assisted phacoemulsification for lenticular coloboma, a new technique with advantages that allows us to perform phacoemulsification most naturally and also tackles the issue of fluid misdirection in the most efficient yet effortless manner.